That being said, I have now clicked the recording button, and here we go. Chapter 11, the principles of pharmacology. We don't, as EMT basics, need to memorize the U.S. pharmacopoeia or anything like that. We have a handful of medications that we do need to know backwards, frontwards, upside down, and inside out, but we're going to get some assistance with that coming up here today when you guys get into class. The one big thing to remember about medication is this, and for those of you who are going to go on and pursue advanced degrees, whether it's paramedic, nursing, doctor, it doesn't really matter one bit. Remember this until the day you stop practicing. Once you give a drug, there's no take backsies. Once you give a patient a medication, that's it. It's in. There's no like, oops, I'd really like to have that back, because you can't get it back. So some of the things and the BLS medications that we're going to go over, it is very important to be right. And if you aren't necessarily sure, there's a whole bunch of ways we can figure out whether or not this is correct or not before we have that oops moment, like maybe I shouldn't have done that. Because this is one of those times, like for real, that you could accidentally kill someone, even at the BLS level. So pharmacology is a big deal. We don't have a lot of drugs, but some of the drugs that we have come with some pretty negative side effects if they're used inappropriately or incorrectly. So getting into that, we're going to talk about how we give drugs, because there are some medications that we can administer. There are some medications that we can assist with. And if we are going to be on the hook for either administering or assisting, we absolutely need to make sure we are up to snuff on knowing our drugs. We'll talk about the procedures for giving some of the medications that we can introduce into a patient at the BLS level. We will talk about some times where maybe we have to get in touch with medical direction in order to use a medication that we would normally just administer to somebody, because there are some caveats written into our protocols, into our BLS standing orders that say, hey, if your patient meets this criteria, you need to call medical direction before you give them this drug. As people age and as we get older and health problems start to mount and all of that good stuff starts to happen, there does come a time where even some of the medications that we would use without question, without even batting an eyelash, may actually make an older patient worse. They may actually not prove to be as helpful as we thought they were going to be, depending on what they take for other medications. And when in doubt, pick up the phone and call somebody, because I'll tell you, doctors get a whole lot longer training than we do. So what is a drug? A drug or medication, depending on how you want to refer to it, is any chemical that is used to treat or prevent a disease or condition. So that is anything we can give our patient to either make them better, or something that they are taking on their own, prescribed by a physician, that is supposed to help with a disease that they have already been diagnosed with. The study of drugs, that's called pharmacology. I'll tell you, my oldest son just finished his 3rd year in a Doctor of Pharmacology program, and in no way, shape, or form would I have any interest in doing what he plans to do for a living, because just the amount of things that poor kid is expected to know is absolutely mind-boggling. They've gotten to do some cool stuff, like who would have thought that in the study to become a pharmacist, you would actually take a chemistry class where you synthesized and created and made your own aspirin. That's pretty neat. But some of the other things that go along with the study of pharmacology are just wild. We are going to carry certain medications on us. Any medication that we carry in our jump kits and in our ambulance, those are the medications that we can administer. Any medications that we would use that we are going to borrow, say, from our patient, those are medications that we can assist with. Anybody out there catch the subtle difference between administer and assist?
We can, with administer, we can do it ourselves. But with the assisting, it has to be with someone else's medication or with a paramedic on the truck.
Perfect. When we're gonna administer something, that is medication that I'm taking from my own stock. I've done an assessment and I have said, yes, this patient is suffering from condition whatever. And the medication that I know that will be useful for that condition is this. And I can get that per my standing order, introduce it to the inside of this patient in one way, shape, or form, and I'm expecting certain reactions, certain results, and at the end of it, to treat this patient's disease process. When I'm assisting with a medicine, I am taking the patient's own medicine. We're going to talk about the 6 patient rights here in just a couple of minutes, but I am going to instruct and sort of coach the patient on appropriately using their own medication that someone else has prescribed to them. Because there's a very fine line there between administer and assist. Years and years and years ago, when I first got my EMT certification, we were not allowed to administer epinephrine to an anaphylaxis patient. So that means I could have been standing there watching somebody rapidly trying to die right in front of me. And unless they had their own epinephrine auto-injector, an EpiPen, for me to assist them with, they just died. If we fast forward a few years now, epinephrine, auto-injectors, EpiPens, whatever you want to call them, have shown to actually, when used appropriately, save lives on many fronts. And now we carry our own EpiPens in the truck, and we will administer epinephrine rather than assist the patient with their own. We have training at this point, actually, and it's something that we'll go over, if not today, very soon, to actually draw up epinephrine from a multi-dose vial and inject it with an IM injection into our patient instead of using an EpiPen. And if that's not the height of medication administration, I don't really know what is, because now you are actually taking the physical drug, withdrawing it from something, and injecting it into your patient. EpiPens are pretty simple. We're going to go over a couple of safety things with those today, and really, they are almost mess up proof, to be perfectly honest with you. The only couple things you got to worry about is making sure that you don't put your thumb over the end, because that needle will go straight through your thumb. Other than that, when we get into, in the next couple of days, talking about anaphylaxis and how a patient who is in anaphylactic shock presents, they do everything but jump up and down and wave at you and say, "Hi, I need an EpiPen. Could you please come give this to me so I don't die?" And we run through our assessment. We run through our 6 patient rights, because that's how we verify that, yes, this drug is indicated for this patient. I'm doing the correct thing. And we administer the medicine. All drugs are going to have specific effects on the body. We'll talk with things like epinephrine or albuterol or nitroglycerin for our chest pain patients about what those effects are and why they make the patient better, both today and moving forward. But know that with some of these medicines that we carry, they're emergency meds. We are giving them in an emergent situation for a patient who is really significantly ill. You may actually, in no time flat, watch that patient turn the corner at the flick of a wrist or the snap of a finger and really significantly improve. So knowing when to use these meds and how to appropriately use these meds is going to be part of our bread and butter here. Now, I'll tell you, it's not something that you'll do all the time. We are not out there just jabbing people with EpiPens and handing out nitroglycerin and starting albuterol nebs and doing all sorts of crazy things, because it's just not the way really the ball bounces. So being a student of the game and staying up to date on your treatments and your protocols and your indications and your contraindications is really something that you have to hold yourself accountable for. So here are the medications that we will commonly administer. Those are oxygen, first and foremost, aspirin, albuterol, nitroglycerin, glucose, and Narcan. Those are the ones that those are really the 6 that we need to know very, very well, because those are the 6 that we can administer without really speaking to anyone. We are all about business at that point when it comes down to, am I going to give this medication? The 2 medications that you can assist with are albuterol and nitroglycerin. Now you notice I said albuterol twice. Most of the time when we show up for an asthma patient who receives albuterol through their metered dose inhaler, does anybody out there have asthma? Know someone who has asthma?
I have it.
have asthma. Yeah.
So they write you a prescription for that albuterol inhaler. They give you next to no information on how to use it, and they send you on your merry way. They tell you to use it as needed when you feel the onset of an asthma attack. Okay, cool. And one of the things that a lot of asthma patients do, because, not being able to breathe is a big deal, people get nervous, is they take that albuterol inhaler and 25 times they squeeze the actuator and try and pump that medication into them. Add to that the fact that they're not breathing appropriately. They don't have the proper rate, rhythm, and quality. They don't have the proper tidal volume or minute volume. And none of that medication gets down to where it needs. So we carry albuterol in our ambulances in nebulized form. We can actually now administer that medication as opposed to assist with that medication, because generally speaking, by the time we're called and we arrive at the bedside of a patient who's having an asthma attack, using an inhaler that they've already used a bunch of times, are we expecting a positive result from that?
Absolutely not.
Yeah, it's like peeing into the ocean to warm it up. I mean, it's just not going to work. So we can actually start an albuterol nebulizer and now provide for them a much better way to get that medication down into their lungs and all the way down to those little respiratory bronchioles and alveoli to open things back up and get them breathing appropriately.
The
There's
oxygen.
the difference between administer and assist. We can administer nebulized albuterol. It's a much more effective and efficient way to give that drug to a patient who's in the middle of an asthma attack, because we know that assisting them with their albuterol inhaler over and over and over and over and over again isn't going to be effective. And the last drug we can assist with is nitroglycerin. Nitroglycerin is a medication that we will give patients for chest pain, but we don't take it from our own stock. We do not carry nitroglycerin on a BLS ambulance because nitroglycerin can really be a dangerous medication. It has interactions with other drugs. It is a very, very potent vasodilator. A vasodilator is a medication that when it gets inside of our patient, it opens up all of our patient's blood vessels, maybe double or triple the size. We don't have enough blood to fill that tank. So unless my patient meets a very specific criteria or has already been evaluated by a cardiologist, we can't safely give them that nitroglycerin, so we don't carry it on our ambulance. Nitroglycerin, absolutely, when given at the wrong time or to the wrong patient, can have very, very negative consequences. We'll talk about those. So just in case you need it, here's another quick look at the medications that we stock. These are the medications that we can administer. So we have oxygen, baby aspirin, adult EpiPen, a junior EpiPen, glucose, Narcan, and albuterol. We'll talk, and I know your book is going to tell you some things about the administration of oxygen. When you guys get here today, we'll talk about the differences between some of the things that your book is going to tell you and some of the things that the state of Massachusetts wants from you, because the book is written to a national standard. Massachusetts, God bless them, the Commonwealth, they have their own ideas about what some of the standards that we should use are, and those are the ones we are bound to when providing service in the state of Massachusetts. So that's something we'll get into a little bit, and anybody who didn't already want to will want to move and never provide emergency services in the state of Massachusetts as long as they live. When we're finished, I'm going to complain. So here are our BLS assisted medications. Our BLS assisted medications are nitroglycerin or the patient's prescribed inhaler. So there's your list. These are the ones we got to know. And I promise you, you will. So you've heard me mention at least once already the 6 patient rights. These are all of the things that we need to verify either with our patient, with our partner, or some sort of mishmash combination of the two before we administer or assist with a drug. So let's take them one at a time. We have right patient. How do we know when we have the right patient?
We got to look at the prescription bottle and ask the patient, is your medication?
Well, that's a great start. So we'll talk first and foremost about the medications we can assist with. So yes, with nitroglycerin or a patient's prescribed albuterol inhaler, yep, we look and we make sure that we have the patient's name, so it's their medication. We make sure that we have the proper medication. You know, if we can give an albuterol inhaler and somebody hands us a steroid inhaler that does not say albuterol on it, we are not going to assist them with that, because their steroid inhaler is not going to help them with their asthma attack right this very minute. So we need to make sure we have the right patient. What about medications that we carry? There's not going to be any prescription. There's not going to be any label. How do we know we have the right patient?
Just saying the patient's name out loud.
So I get where you're at right now, sort of
Medical alert
verifying
bracelet.
identity. But how do we know that we have the right patient for the drug that we're picking?
We check the label.
Asking the birth date.
So I complete my assessment, and I've gotten to the point where I think my patient is having an allergic reaction, and I think my patient needs epinephrine. That's how I figure out at that point that I have the right patient, because name and birth date and all of those things aren't really going to amount to much. Yes, I need to make sure that I have all of that, and for documentation and billing and just making sure I have stumbled across the right person. Absolutely. But your assessment on the medications that you can administer is what's going to tell you you have the right patient. So listening to your patient's lung sounds, checking your patient's vital signs, being familiar with the signs and symptoms of all of the patient problems for the medications that we can give is going to be how we figure out whether we have the right patient and really the right medication. Because we have 8. It's not like we can just spin the wheel and say, all right, this patient is got something wrong with them. Let's try an aspirin. Let's try some glucose. You have to really get down to the nitty gritty and figure out with your assessment what is going on with this person and what medication from my list can I choose to administer to them and expect that they're going to get better. Right dose. Thankfully, most of the medications that I'm going to expose you to are going to be single dose. So yes, do you have to know what the doses of the meds that we can give are? You sure do. But they're not going to change. We are going to be able to give the same medicine in the same concentration at the same dose to all of the patients because our medications don't change. It's not like we have to, figure out a whole lot of stuff or try and cut doses and figure out, all right, should I give them half a pill? Should I give them the whole pill? That's not the way this works for us. What do you think about right time? What sense does that make?
Administering it at the right time, making sure, like, for example, if they already gave a nebulizer at home, then when we pick them up, is it the right time to give them another nebulizer? Do we wait in between? Like that.
Absolutely. Has there been enough time passed since they've treated themselves? Realistically speaking, for the most part, right? This is emergency medicine. The right time is going to be right now, unless we have some things that make us hesitate, some things that make us think maybe this isn't going to be beneficial, maybe this isn't going to work, and maybe, just maybe, I need to hold this medication instead of giving it. If a patient has already maxed out their dose of nitroglycerin before we arrive, right now is not the right time because they have already taken their maximum allowed dose, which is 3 tablets, 1.2 milligrams total, and us giving them another one is not going to be helpful. As a matter of fact, it's probably likely to make things worse, so we don't do it. We'll talk routes of administration. Again, this is a pretty simple one for us because all of the medicines that we're going to give are only available for one route of administration. It's not like we have to pick, are we going to give this medicine IV? Are we going to give this medicine IM? Are we going to give this medicine PO, which is by mouth? Nope. All of the meds that you're going to be exposed to only go into our patient one way. And then we talked about this a little bit during medical, legal, and communications and documentation. We'll talk about it right now. If you didn't write it down and write it up appropriately, it didn't happen. I'm going to add another layer of that for all of you guys. Not only did it not happen if you don't document appropriately, if you don't document in your patient care report appropriately, Cataldo can't bill for that service, can't bill for that $300 EpiPen that you just used. And if money doesn't come in the door, money doesn't go back out the door in the form of payroll and new ambulances and new equipment. So we need to make sure that we do everything that we're supposed to do and do it appropriately so that the lights can stay on and we can all stay employed. That's something that I think gets overlooked a little bit because, yes, at the end of the day, my main concern, my big focus is patient care. I'm going to make sure that this patient is appropriately cared for, come hell or high water. But we have to make sure that we've dotted all the I's and crossed all the T's by the time that this is all done. Otherwise, I wind up suffering from that indirectly. My paycheck doesn't come in, my paycheck doesn't go up. Maybe we start having to ride around in crummy, broken down ambulances with broken equipment. Maybe the lights go out and we come to work someday and the doors are chained. And that's not likely to happen here. But what I will tell you is it has happened other places. So I think we hit that pretty good. Excuse me. So, do we have any questions about the differences between assisting and administering? Going once, going twice.
Noted.
So,
Assisting, we assist, and administer, we are capable of giving.
perfect. So now let's talk oxygen. Who are we going to give oxygen to?
Somebody who's deciding and retracting and looking blue and cyanotic.
All right, I like it. Some of that stuff is probably going to be a patient will wind up ventilating. But the easy answer to who we're going to give oxygen to is anybody that needs it. Now, we'll hop in my Wayback Machine again here for a minute, and I'll tell you that when I received my EMT certification, everybody got oxygen. If you called for a stubbed toe, you got oxygen. If you had just been run over by a train, you got oxygen. And anything in between, you got oxygen, period. Some was good, more was better. If I could get an entire bottle of oxygen into you, I would put as much of it on as I humanly could. And then we realized we were killing people with oxygen. Oops. They've changed the guidelines. If you look at this, avoid hyperoxygenation. Oxygen is a drug and needs to be administered as such when we're talking in the medical sense. When we were giving oxygen to everyone, you had chest pain, oxygen. You had a stroke, oxygen. It didn't make any difference. And what we were actually doing was making people worse. In high concentrations, you know what oxygen does? It shrinks down my patient's blood vessels. When your patient's having a stroke or having a heart attack, most of those problems are caused by blood clots. Can you think of taking a patient who's got a blood clot lodged somewhere in their brain or somewhere in their heart, and then I come and pour all of this oxygen into them and cause their vascular system to shrink down? What did I just do?
Aren't you you're making it more impossible for the for them to breathe or get stuff circulated in them?
Yeah, not so much breathe, but I am absolutely now, if I took those blood vessels and made them smaller and they were already blocked from a clot, you know what I did? I just locked down the vault. There is absolutely no way this patient is going to get better, and 100% of the time they got worse. We took tiny little itty bitty strokes and turned them into life-altering events. We took small little heart attacks and caused massive myocardial death, because nobody looked at the science and figured out that too much oxygen is really a bad thing. You add to that now, it is possible to have more than a 100% oxygen saturation. There can be extra oxygen just floating around inside of our patient's blood. And when it does that, it becomes very unstable. And I'm not going to get into the wheres and what fors, but what that does when it becomes unstable like that is it destroys things. So adding oxygen to a patient that doesn't need it is going to have negative long-term outcomes. That's why this oxygen administration should be titrated to effect is very, very important. Yes, your patient is going to get some oxygen from you if they need it. Yes, we are going to make sure that we are keeping a reasonable oxygen saturation. So if they have an O2 saturation of less than 94%, or they are complaining of shortness of breath, difficulty breathing, or we'll talk trauma now for a minute, and they have just been run over by a bus, we know that oxygenation is going to be their problem sooner rather than later. So we are going to give them some oxygen. But gone are the days where I would show up and put a non-rebreather mask on every single patient I ever came into contact with. Like I said, stub toe, oxygen. We're going to get it in there. We'll be good. We'll be okay. No, that's not the way we do things anymore. That's not how medicine works.
I have a question. So I know like we are personally supposed to make the decision on if they get oxygen or not. But if a patient gets in the truck and they're pretty much saying like I want oxygen, do we have to take their word for it and give it to them because they're requesting it, or you just like you have to make the ultimate decision and if they get it or not?
So very infrequently will you hear a patient say, I want oxygen. Maybe they'll say, I need it. But if somebody just says to you, I want oxygen, figure out why. Because there's more questions to be asked there, and that'll be part of the assessment that we talk about in the next, well, today, in the next few minutes. But yeah, dig a little deeper if somebody says, oh, I want oxygen. because there are some things that we can look for as to why we would give this patient oxygen. So we're going to look for the signs and symptoms, follow the assessment. Does my patient have shortness of breath? Are they presenting with some respiratory distress? Do they have a rapid respiratory rate? So when we talk about respiratory rate, generally accepted normal rate of breathing is somewhere between 12 and 20. So if they have a respiratory rate that is over 20 breaths per minute, we're going to call that rapid breathing. And we're going to probably administer some oxygen to that patient, because whatever is going on inside of them physiologically is forcing them to breathe faster. It's not a normal process. It's not something that we like to see happening. Same thing goes with fast heart rate. If their respiratory rate goes up to get more oxygen in, their heart rate generally follows to move more oxygen around. So if we start to see signs and symptoms of shortness of breath or respiratory distress, some of those retractions or cyanosis that I believe it was Jessica, right, mentioned a little bit ago.
Yeah.
And we start to see an increase in their respiratory rate and an increase in their heart rate, we know that their body has kicked into overdrive and physically their body is demanding more. So these are things that we can look at and see them for the sign and symptom of difficulty breathing and respiratory distress or hypoxemia that they are. Hypo, low, oxygen, emia in the blood, low oxygen in the blood. Some of those other things that we look for, the poor perfusion. Poor perfusion means, are they adequately circulating oxygenated blood to all of their tissues? That cyanotic color, that bluing of the skin, is going to be a late sign that no, they are not perfusing well. Any changes in skin color, temperature, or condition during our circulation check of our primary assessment is going to be signs of poor perfusion until proven otherwise. These are people that we will administer some oxygen to. But when you go to the doctor and they write you a prescription, they don't write you a prescription for as much of the medicine that they're going to prescribe to you as is safe to give. They start out small. If you go in and your blood pressure is a little high and they're going to put you on a medication, they start you on a medicine of like 5 milligrams as opposed to 80 or 100 milligrams of a medicine, because they're going to titrate to effect. If 5 milligrams of something will get your blood pressure down, they stop at 5. But if 5 isn't quite helpful enough, they move up to 10. We need to do the same thing with oxygen. So generally, we're going to start right here. We're going to give them between 1 and 6 liters per minute with that nasal cannula that Kat and them showed you last week. And if the 1 to 6 liters per minute help their shortness of breath, their respiratory distress, and slows their breathing rate and heart rate down, we stop there. If the 1 to 6 liters per minute with a nasal cannula don't help and we don't see our patient beginning to improve, we're going to titrate to effect, and maybe we'll move up to a non-rebreather mask and set it somewhere between 10 and 15, or I think your book might say 10 and 12 liters per minute. Okay, that's great, because now we've tried the nasal cannula, it didn't work, we're actually performing some medicine here, and we're moving up a little bit in order to try and help our patient get better. And sooner rather than later, if we can't fix this hypoxemia and these signs and symptoms of respiratory distress, maybe our patient moves into respiratory failure. In respiratory failure, our patient's body is no longer able to rise to the occasion. It no longer is meeting its own needs with oxygenation, so it's not getting enough oxygen in, it's not getting enough oxygenated blood flow moved around, and now the body is beginning to fail. Well, we got to fix for that too. We switch to a bag valve mask, set it at least 15 liters per minute, and we take over and ventilate that patient on our own. They may be conscious, they may be alert, they will be scared witless, but we're going to ventilate them with a BVM, one breath every 5 or 6 seconds, and try and reverse some of that respiratory failure and try and change some of this low oxygen in the blood. Moving right along, now we're going to talk about how, why, and when we would administer our aspirin. Aspirin is going to be given to a chest pain patient. Almost every chest pain patient is going to receive aspirin from us. 81 milligrams a piece. We are going to give a total of 324 to 325 milligrams chewed. So that is 4 81 milligram baby aspirin tablets. When are we going to give this? Yo,
Is it true that I believe it's the Tylenol that is for like your back and whatnot, and then I think it's at aspirin for like your head. I know it's some form of that.
so I worked with a doctor once upon a time when I worked in the jail, and he told me that the 3 best cures that were ever invented for a headache are aspirin, nicotine, and caffeine. So you're on the right track. But we're going to give baby aspirins in a much different light for a much different reason. We're going to give this 324 milligrams of chewed baby aspirin for chest pain. And we're not giving it to relieve the pain. We give our aspirin for its anticoagulant properties. Aspirin will actually prevent blood clots from getting bigger. It's not going to break them up. It's not going to make the chest pain any better. It's not going to reverse any of the things that are going on inside of our patient. What aspirin does is it interferes with our blood's platelets' ability to stick together. So if our patient's having chest pain from a blockage in one of their coronary arteries, we're going to give them this 4 aspirin. They're going to chew it up, they're going to swallow it, and then pretty much from that point on, the blood clot in that coronary artery is going to stop getting bigger. Those platelets that are going by that blood clot, they're not going to be able to stick to that blood clot and make it any larger. If that clot doesn't get any larger, and some blood was getting past it to begin with, some blood will continue to get past it. And if blood is being delivered to the tissues of the heart, we may be able to keep and prevent a myocardial ischemic event, which is those tissues not getting enough oxygen, and prevent it from turning into a myocardial infarction. Myocardial infarction is the medical term for a heart attack. It means death of the myocardium. Myocardium, myo is muscle, cardium is heart. So myocardial infarction really means death of heart muscle. If we give those aspirin and they work and they do what they're supposed to, and those platelets don't stick together and that clot doesn't get any bigger, we are allowing that tissue to still be perfused, which means we have probably done the best thing we possibly can for this chest pain patient. Now we also need to know when not to give it. I talked about clotting, and I know we've mentioned clotting here and there. Blood clots are sometimes good, sometimes bad, right, folks?
Yes.
Yeah, if I lose an argument with a saw, blood clots are good. If I'm having a heart attack, blood clots are bad.
Yes.
If I have a GI bleed, blood clots are good. It is entirely possible with the amount of vascular structure surrounding our gastrointestinal tract and the amount of blood flow that passes by our GI system that I could bleed to death from a gastrointestinal bleed. If your patient has an active GI bleed, we don't want to give them any aspirin because we don't want them springing new leaks. If they're having chest pain, we don't need them also bleeding to death. So no aspirin at that point. And the last little bit of contraindication for our aspirin is if my patient's allergic to it. when we are going through our sample history that we're going to talk about here shortly, the A in sample history stands for allergies. Do they have any allergies to food, medication, or anything? If I'm getting ready to give my patient 324 milligrams of chewed baby aspirin and they say, I have an allergy to aspirin, guess what I am no longer getting ready to give them? Aspirin. That has been taken out of my toolkit.
Depends.
What if we administer, like, let's say a patient is unconscious and we administer a medication that they are allergic to, but we can't, obviously we had to administer it because that's what we thought would be right. But they end up having a reaction. What happens then?
So this right here is the only medication that we would even be able to give to a patient who is unresponsive. None of the other things that we carry could we give to someone who's unresponsive. And if your patient is unresponsive from an anaphylactic reaction, epinephrine via autoinjector is not likely to help them. As far as what do you do with an unresponsive patient, we'll get into that a little bit later on when we do patient assessment today. So let's talk about epinephrine. I mentioned that nitroglycerin is a very potent, very strong vasodilator. It makes our vascular system bigger. Epinephrine is the exact opposite.
It opens it up.
Nitro does. Epi closes everything. One of the big, well, not everything, but it closes down the vasculature. Epi, when we use the auto injector and have that IM injection slingshotted into our patient's leg, epinephrine clamps down all the vascular structure. One of the big problems with our anaphylaxis patients is they wind up very hypotensive. Hypo, low, tension meaning blood pressure. So their blood pressure goes way, way low. Because with an anaphylactic patient, the body dilates all the blood vessels. So we stick them with an EpiPen, and then epinephrine goes in and clamps everything back down, and their blood pressure goes up. Well, if their blood pressure goes up, we've just restored some of their perfusion. Epi does the exact opposite in the lungs. When we introduce epinephrine into a patient's thigh, lateral aspect of the thigh, we're going to hold the EpiPen there for somewhere between 5 and 10 seconds. We will massage the area. We'll get all that vascular structure to clamp back down. My patient's blood pressure will go up. Epinephrine, when it gets into their lungs, actually relaxes the smooth muscle in our patient's lungs, in their lower airways, around those bronchioles, and it makes them bigger, and it makes it easier for them to move air in and out. And that epinephrine, relaxing those smooth muscles that are surrounding those respiratory structures, actually now reverse one of the other problems with my anaphylaxis patient. Anaphylaxis is one of those times that we are actually sitting there watching somebody rapidly try to die right in front of us. And epinephrine is the first line treatment, whether you are a ER doc in Boston or a brand new EMT in Malden. Epinephrine is going to be the number one thing you can do for this patient. Now we have two different EpiPens. We have an adult dose, we have a pediatric dose. Our adult dose is going to be 0.3 milligrams intramuscular IM, and we can repeat it after 5 minutes as long as our patient either hasn't gotten better or our signs and symptoms of anaphylaxis have returned. What we're looking for to verify anaphylaxis is, first and foremost, were they exposed to something that they have an allergic reaction to? And then we're going to look at some signs and symptoms. Anybody remember from the airway lecture what stridor is?
It's the sound coming from your upper airway when it's constricted and you can't breathe.
Yeah, our anaphylaxis patient suffers some pretty significant constriction in their airway, in the upper portions of their airway. Anaphylaxis causes lots of swelling. So their face will swell, all their mucous membranes will swell, their trachea will swell and start to close. Bronchospasm. Did Dennis mention anything about wheezes when you guys were talking with him on Friday?
He did.
Yeah, wheezes are the sound of bronchospasm. That's what an asthma patient sounds like. That's what an anaphylaxis patient will oftentimes sound like when we listen to their lung sounds. So now we have an airway problem. We have a breathing problem. We'll add possible severe abdominal pain to that list. When the body's under attack and it can't adequately perfuse the important places, one of the things that it does, one of the mechanisms that it uses to try and compensate is it shunts blood away from places that aren't important. Now, your GI tract requires a ton of blood to do its job. And the body goes, you know what? The brain, the heart, the lungs, we need that blood. So it clamps down and shuts off all the blood supply to your GI tract. So the patient who's having a true anaphylactic reaction a lot of the times will complain of some real significant indigestion or possibly even nausea, vomiting, diarrhea. So we have an airway problem, we have a breathing problem, we have a circulatory problem. Then we'll get into another breathing problem, respiratory distress. They'll tell you that it's difficult to breathe. They'll have a rapid heart rate. We'll see signs and symptoms of shock. In your primary assessment, when you do that skin color, temperature, and condition, you are actually looking for an identifying shock and you don't even know it. When you see that changes to their skin color, temperature, and condition, you've found a circulatory problem. You've found a perfusion issue. You see swelling of the lips, well, there's another airway problem. Swelling of the tongue, there's another airway problem. Swelling of the face, there's another airway problem. So knowing nothing else about anaphylaxis other than the few minutes that we've talked about it right now, do you remember your primary assessment talk you guys did with Will? Was that Thursday?
Yeah, well, our initial, when we go in and we have to look at the person and perform a general impression, whether we stay and play or scoop and screw.
All right. And I'm sure he went over just how important airway, breathing, and circulation are to our patient, being alive.
Yes.
And anaphylaxis is killing all three of those things: airway, breathing, and circulation. Anaphylaxis and true anaphylactic shock is one of the times where the patient's body is absolutely trying to wipe them out. And we fix it with epinephrine. So I mentioned there are times where we need to call medical control for one drug in particular, and this is the one. If our patient is over the age of 65, we don't necessarily want to give them an EpiPen. Epinephrine clamps down the vascular structure, makes our patient's blood pressure go up. Epinephrine speeds up my patient's heart rate. Epinephrine speeds up my patient's respiratory rate. Epinephrine is the chief hormone in your fight or flight response. That, am I going to run away from this bear or am I going to stay and fight it? Epinephrine speeds you up. Epinephrine has you wired for sound. Why wouldn't we want to give it to somebody who's over the age of 65 without talking to a doctor?
Because it can cause heart attack, heart failure, and a lot of.
Circulatory issue.
Yeah, their circulatory system might not be able to hack it. If we give them that epinephrine, maybe we cause that vascular structure to clamp down so much that we cause a heart attack, or we cause a stroke, or we have their heart speed up so fast that it does go into failure. So we get on the phone with medical control, we talk to the doc, and the doc will tell us either, yes, go ahead and treat this anaphylaxis and we'll deal with the circulatory problems when they show up, or no, transport this patient and hurry up about it and get him to the emergency room and we'll deal with all of it when we get here. Thanks, have a nice day. It's really that simple.
I have a question. So like, let's say like we call med control and they say we can give it to them. Are we allowed to give them the junior dose of epi, or do we have to like do we have to give them the adult because the junior probably wouldn't work?
You'd give them the adult. Yeah, we don't, underdosing someone with medication is just as bad as overdosing them. If the doc tells you to go ahead and give them epinephrine, confirm with them that it's the 0.3, but no, that you wouldn't give them the half dose here, because epinephrine is weight based. We decide epi junior versus epi adult based on how much does my patient weigh. If your patient is over the age of 6 months and under 25 kilograms, which is 60 pounds, they're going to get the 0.15 milligram junior epinephrine. If your patient is over the age of 6 months and over 25 kilograms or 60 pounds, we are going to give them the 0.3 milligrams of IM epinephrine. If you need to give a pediatric patient a second dose for recurrent anaphylaxis, or the fact that they didn't improve from the first dose, you have to call medical control. For pretty much the same reasons as the elderly. We don't want to take the chance of messing with their cardiac and vascular system too much if we can avoid it. Our indications for junior epinephrine, pretty much the same. Respiratory compromise, airway, breathing, and circulation problems. And if they're under the age of 6 months, we're not going to administer epinephrine. We're going to call medical control. Babies under the age of 6 months are still surviving and thriving off of mom's immunity. So they are still living off of immunity that they got when they were in utero, or immunity that they are receiving from mom in the form of food. It would be very, very strange for a child under the age of 6 months to have a true anaphylactic reaction. Anaphylaxis doesn't happen the first time someone's exposed to something. Under the age of 6, they haven't been exposed to much. Under the age of 6 months, they're still protected by mom. So we get on the horn and we call the doc before we start jabbing little 5-month-old infants with epinephrine. Next, we're moving on to oral glucose. Oral glucose, another one of those ones that is pretty straightforward and simple. Our oral glucose dose is 1 tube. 1 tube is 1 dose. Our indications to use it are for a symptomatic diabetic patient whose blood sugar is below 70 milligrams per deciliter. 70 is the cutoff. Generally, depending on which book you read, normal blood sugar is listed between 70 and 110 or 80 and 120. When blood sugar falls too low, our patient's going to have some obvious signs and symptoms generally. They'll have a decreased level of consciousness. Maybe they'll be acting sort of funny and out of character, and we'll be able to document that. We'll also be able to check their sugar. And as long as they are conscious and able to speak to us, follow directions, and swallow appropriately, we're going to treat them with a tube of oral glucose. We take that little tube of sugary gel-like, it's awful, and we tell them to squirt it between their cheeks and gums and just let it sit there and melt. It's going to get into their bloodstream faster. Their body doesn't have to use any energy to do anything with it. And this oral glucose is going to bring their blood sugar back up to what is considered a, quote, normal level. And we'll watch our patient's level of consciousness return to normal. We'll see our patient get better. We'll reassess their finger stick blood glucose, and we will see that it has come up some and it is no longer below 70. And again, a medication that you can administer as long as it is done appropriately, you'll watch your patient get better. Why do you think this patient has to be conscious and able to speak and swallow and follow directions?
Because they have to squeeze it themselves in between their cheeks and swallow.
When you get a low blood sugar, you start acting disoriented, sort of like if you were drunk and combative and stuff. And so sometimes they don't know what they're doing, and like, you know, they can't necessarily like swallow or put stuff in their mouth because the sugar is so low that they're just so disoriented. They don't, you know, they lose all type of mechanics.
You're both right. And if I take and put something into my patient's mouth when they're not able to listen to me and follow my instructions and swallow it appropriately, what kind of problem did I just create besides a big one?
A breathing obstructive problem.
I've obstructed their breathing by obstructing their airway. They're going to aspirate all that sugary goodness. And I have just taken a patient who was kind of sick and made them a lot of sick. That's really not the best way to go about my day. I prefer to work smarter, not harder. And if my patient can't speak and isn't conscious or can't follow my instructions or swallow and protect their own airway, nothing by mouth, period. If your patient is altered and can't protect their own airway, they get nothing in their mouth. End of story. Now we'll move on to naloxone, Narcan. This is pretty simple and straightforward for us as EMTs. What I can tell you professionally is this is the absolute most inappropriately used medicine that has ever been invented. Ever. Why do you think I say that?
They would think everybody that's passed out in Chelsea is overdosing.
Fact number one. I had a student who brought his mother to a doctor's appointment and took a nap in his car, and he woke up just as the fire department was getting ready to Narcan him. Now, what did you guys learn in CPR? How do you verify your patient's level of consciousness when you think they're unresponsive?
Tap them on the shoulders or do a sternum rub to wake them up.
Yeah, sir, are you okay? Give them a little tap, give them a little rub on the sternum. Guess what people who are alive and capable of being conscious do at that point?
Wake
Wake
up.
up.
Wake up and go, God damn, would you stop that? That hurts. People that aren't overdosed, first and foremost, don't need Narcan. Secondly, people that are overdosed don't always need Narcan. The way these opiates work is they get into our patient's bloodstream and they shut off their central nervous system. Large amounts of opiates get in and they just turn out the lights. So that epinephrine that I told you was the body's ability to compensate, and it speeds everything up and lights you up like a Christmas tree, opiates take that away. So their heart rate goes down, their respiratory rate goes down. And really, what kills an opiate overdose patient is respiratory failure and hypoxia, hypoxia, low oxygen in the blood, because their respiratory rate goes well below that normal 12 to 20 down to maybe 4. They might breathe 2 times a minute. So if you roll up on a patient who's only breathing 2 times a minute, what's something you can do to fix that?
Ventilate or add a
Yeah,
bag valve mask.
break out my trusty BVM and I start ventilating this patient, because on top of whatever caused their respiratory depression, low oxygen in their blood is going to be a problem. The brain doesn't do well when there's no oxygen around. So I need to make sure that before I correct this overdose problem, I need to make sure this patient is oxygenated. So I will ventilate my opiate overdose patient for somewhere between 3 and 5 minutes to correct that problem. Because if I don't correct the hypoxia, if I don't fix the respiratory issue, all the Narcan in the world is not going to save this patient. Because we introduced Narcan into our patients via the intranasal route. So I take this medication, I have an atomizer that I screw onto the end, or I have another way I can give it where I just stick something in their nose, I push a button, and it sprays this medicine. If that patient's not breathing, where does that medicine go?
Into their lungs. I mean, into.
The true answer is absolutely nowhere.
Yeah.
If that patient isn't breathing, they're meant to inhale all that atomized spray and get it moved out into their circulatory system. If this opiate has turned off their central nervous system and slowed down their respiratory rate and slowed down their heart rate and caused wide scale low blood pressure, all I'm doing with Narcan as I squirt it into my patient, squirt it into my patient, squirt it into my patient, and just keep going is filling them up like a water balloon. Because if we're not ventilating the patient, we're not treating the patient appropriately. Our dose of Narcan is 2 to 4 milligrams intranasal. It depends what you're going to carry on your truck, whether it's a 2 milligram dose or a 4 milligram dose. But the way we administer Narcan is just like this. And Narcan is so widely available that someone will probably already have Narcaned this patient before you show up. So we show up and we ventilate for 3 to 5 minutes right there on the sidewalk. And once we ventilated for those 3 to 5 minutes, their O2 saturation has probably come up a bunch. We have reversed the hypoxia. We have now fixed part of the problem. So we're going to go ahead and give them either a 2 or 4 milligram intranasal spray of Narcan. And then we're going to go right back to ventilating this patient for 3 to 5 minutes. And then, and only then, if your patient needs another dose, do you give another dose? So you have already worked on this patient for 10 minutes and only given 1 dose of Narcan. We're going to see for our signs and symptoms, what are our indications? We'll have a suspicion of an opiate overdose, altered mental status, low blood pressure, low respiratory rate, low heart rate, maybe some signs and symptoms of drug use. And that's going to tell you, ventilate this patient for a while, 3 to 5 minutes, then give your dose of Narcan, then go right back to ventilating, because we need to fix the respiratory problem. Fixing the overdose problem's not really going to do us a whole bunch of good, because generally people, when they wake up from an overdose, are so hypoxic that they wind up wanting to fight with everyone because their brain is not functioning appropriately because it doesn't have enough oxygen. So we fix the oxygen problem first, because I don't want to fight with somebody just because I can. So I ventilate for a little while before I get all cowboyish and start squirting people full of Narcan, because it's a better way to treat your overdose patient.
And we can do that. That's proper protocol. That's perfectly fine once we come up
This
to the
is
same
this is
necessity.
exactly the way the protocol is written.
Right. Okay.
Nobody does it, but it's exactly the way that it's supposed to be done.
Okay.
So I had a couple of asthma folks out there in the audience, and what we're going to talk about next is the medication we use to treat bronchospasm or reactive airway disease. It's called reactive airway disease because the problem with our asthma patients is bronchoconstriction. Those bronchioles that are down in our lungs are surrounded by smooth muscle. And when our patient begins to have an asthma attack, those smooth muscles contract and seal off those bronchioles, which close off those alveoli and make it impossible for our patient to ventilate and oxygenate. And what we do with this albuterol is we have them exhale maximally, blow out as much as they can. We have them take their inhaler, put it up to their lips, and squeeze down on this little canister as they're inhaling. And then the next most logical thing that I tell this poor patient who can't breathe, the next words that leave my mouth are, "Now I want you to hold your breath." And they look at me like, "For real? If I could hold my breath, you wouldn't be here." I know. That's why most of the time we talk about these albuterol rescue inhalers not really working as far as once we get there, because the patient's already tried that and it has not been successful. Here at Cataldo, we carry nebulized albuterol. We have this little can that we can squirt an albuterol bullet. We call them bullets. We will squirt that little albuterol bullet into this nebulizer can. We will screw and put our equipment together, and we will hand it to the patient and tell them, all right, now I just want you to breathe nice and deeply, but normal. So we don't tell the respiratory distress patient to hold their breath anymore, which is nice.
I have a question. These look like the they already come mixed with the
Yep,
saline and albuterol.
yep,
So they're pre-mixed. We just open the bullet and put it in.
yes, ma'am.
Cool.
So albuterol inhaler, pretty straightforward. Patient has to have their own. We walk them through the steps of using it and using it as directed. That's our standing order for an albuterol inhaler. Our albuterol nebulizer is a bit different. First of all, they must meet all of these following things. They have to be experiencing respiratory compromise. Well, again, we'll file this into the common sense department. They probably wouldn't have called us if they weren't experiencing some sort of respiratory compromise, right? If we get there and my patient says, I have asthma, but my ankle's broken, we're not going to give them albuterol because they're not complaining of a respiratory problem. They're complaining about the broken ankle. They must have a current diagnosis of some form of reactive airway disease, something like asthma or COPD. They have to have a current prescription for an albuterol rescue inhaler. We're not just going to give this to anyone and everyone who wants it. They already have to have been prescribed this medicine by a doctor. They have to be older than 6 months, and they cannot have any history of cardiac disease. Albuterol, as much as it relaxes the smooth muscle and makes breathing a bit easier, it also gets in and acts on some things in your heart and actually makes your heart rate go sky high, especially in nebulized form. So we will not give this to someone who's got a history of chest pain, got a history of heart attack, or a history of any cardiac disease. Now we have to talk to our patient a little bit. Now, I don't know sometimes why they write the protocols the way that they do, but believe it or not, you are actually expected to ask this question right here from our statewide treatment protocols. Would you like us to assist you in taking the same type of medication you take when you have an asthma attack? Now picture this. A patient who is scared to death is suffering from this reactive airway disease. Their bronchioles and their lungs are all closed down. They can hardly breathe. And you have to take the time to ask them this question. They probably, there's got to be some sort of legalese that makes this necessary. I don't really know what it is, but just know that you have to explain it to your patient. I guess we're probably trying to get into the informed and expressed consent angle here a little bit, but make sure you say, hey, I can give you something just like what you take, but only better. Do you want me to? And they're likely to say yes, because they didn't call 911 because they wanted to die from respiratory failure. They called 911 because they wanted you to show up and make them better. Last little bit of cover yourself is you must request an ALS intercept. If you are going to give someone an albuterol nebulizer from your Cataldo ambulance, you have to call dispatch and request for them to send you a paramedic. Notice that that does not say you will wait for that paramedic. You just got to ask for one. Whether or not you get one is completely immaterial and has nothing to do with you. You just have to be able to write in good faith in your report that you asked for one. Here is your dosing for your albuterol nebulizer. It is 2.5 to 3 milligrams in 3 mLs of normal saline. That is going to be one bullet. That's our adult dose. Our pediatric dose is half. It's 1.25 milligrams in 3 mLs of normal saline. The way we make that is 1 albuterol bullet and 1 saline bullet. We're going to dilute our pediatric medication. And you will be amazed at how quickly and effectively this medication works if albuterol is going to be what helps this patient. If it's not, then we're talking apples and hand grenades at that point, and you better get moving towards the emergency room. When you guys finish this program and you go through orientation, we'll teach you a bit more of things that we can do to help our asthma patients, but that is another one of those where Massachusetts is different from everybody else, but in a good way. It's the only one I can think of where Massachusetts does something that not everybody else does, and it's actually fantastic. Last but not least on our little pharmacology talk is going to be nitroglycerin. Nitroglycerin is also a medication that we're going to give to our chest pain patients. Nitroglycerin is, like I said before, a potent vasodilator. This is going to be for chest pain indicative of acute coronary syndrome. If my patient got hit in the chest with a baseball bat or a golf club or had recently been stabbed, they're not going to get nitroglycerin. I have to go through my assessment and say, it seems to me like this patient may be having chest pain related to a cardiac issue. It has to be the patient's own nitroglycerin. If Bob and Sue have been married for 56 years and Bob's having chest pain and Sue says, well, he's not prescribed nitroglycerin, but I am. Here, we'll give him one of mine. No dice. Nitroglycerin is a medication that absolutely can accidentally kill someone. Our maximum dose is 3 tablets. The tablets or sprays come in 0.4 milligrams each. And when we get there, if the patient has already given 2 doses, we can only give 1, because any doses administered prior to our arrival are going to count in that maximum dose of 3. My patient's systolic blood pressure has to be above 120 milligrams of mercury. And why do you think that is? If I take and expand all my patient's vascular structure, which way is their blood pressure going to go, do you think? Up or down?
Down.
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 So if their blood pressure is not at least 120, and I expand that vascular structure, let's say their blood pressure is 94, barely enough to actually be circulating blood, and I give them a nitroglycerin and I cause a precipitous drop in their blood pressure, what did I probably just do?
Make everything worse.
Yeah, I probably just killed somebody is the real answer to that.
Oh.
So we have to make sure we follow our protocols. You can give your first dose after you verify that your patient, yes, is having an acute coronary syndrome. They do have a prescription for nitroglycerin, and their blood pressure is above 120 systolic. Then you wait 5 minutes, and you check their blood pressure again. And if they're still having chest pain and their blood pressure is still above 120 systolic, we are going to give them another nitro tablet. And then we are going to wait 5 minutes. And we are going to see if they're still having chest pain. And if their blood pressure is still above 120 systolic, we're going to give them another nitroglycerin. If at any point throughout this, either their chest pain goes away or their blood pressure goes below 120, no more nitro. And the last little bit we need to know about our nitroglycerin is that if our patient has taken any PDE5 inhibitor medications within the last 48 hours, we're not going to give them any nitroglycerin. PDE5 inhibitors are the medications that are marketed for erectile dysfunction. Things like Viagra, Levitra, Cialis, and any of their any of their non-brand name mixtures, all of those medicines are very targeted, very directed vasodilators to one specific area of the body. Nitroglycerin is a wholesale vasodilator. Nitroglycerin goes in and goes, all right, party, we're going to dilate all the vasculature. When nitroglycerin and things like Viagra get inside of our patient at the same time, they feed off of one another, and the vascular structure expands to a point where they just die. Period. End of story. They just die. That patient will go from conscious and alert but having chest pain to unresponsive and in cardiac arrest right in front of your very eyes very shortly after that nitroglycerin enters their bloodstream. So when we ask our patient, do you take any medications during our sample history, it is very important to pay attention to the medicines that they tell you that they're taking. And if you think, or if you have seen their medication list, and we have a prescription for Viagra and a prescription for nitroglycerin, and they say, oh, no, I don't take that, I don't need that, whatever. Like, all right, well, I just wanted to make sure because I see it here on your medication list. And if you've taken it in the last 2 days and I give you this nitroglycerin tablet, you'll die right here in front of me and there won't be a blessed thing I can do about it. And that's real world application right there, because that is the God's honest truth. Their blood pressure will sink to a point where you won't be able to fix it.
What about if a patient lies to us and because they're just too embarrassed? Because I can see that being something that a patient is embarrassed about, not wanting to admit, even though it's on their list and they said, oh, I haven't taken it in 2 days. And you're like, okay, well then, just so you're aware, this is a risk. If you have, I mean, I know 9 times out of 10, if we say what the risk is, they'll probably tell us. But if they don't and we give it to them and that happens, what happens?
Nothing to you. As long as you document it appropriately and, that is truly what happened, we're not human lie detectors, right? We can't tell whether the patient's telling us the truth or they're not telling us the truth. So if your patient doesn't tell you the truth about something and something bad happens to them on the flip side of that, there's nothing you can do about it, and there's nothing that anybody can do to you. All right, anybody with any pharmacology questions? All right, so here's what I'm gonna do. I
actually have a
closing.
quick question
All right, shoot.
I have a quick question about it has nothing to do with pharmacology, but we took the FEMA, and I actually had a question. During a mass casualty, are EMS personnel on call immediately in situations like that?
No.
Okay.
Nope. All right, so here's what I'm gonna do. I'm gonna close out the meeting, and then I'm gonna instantly reopen it and start it over again, just because I want that recording separate. And then we are gonna go on a break because I rambled on for almost an hour and a half, so you guys deserve a break. So sign right back in once I kick everybody out of this meeting, okay?
Okay.
All right, somebody listened. Good. Off we go.